This is April Van Buchen, and the concepts covered in this presentation are functional ability and mobility. Functional ability is defined as the capacity of an individual to perform activities that can be normally expected by someone at any given age. It brings together biological, physiological, and social capacities. In order to assess functional ability, you must know their development level, neurologically, metabolically, musculoskeletally, whether they've reached developmental milestones, in order to assess their ability. One thing that the RN must do is to be able to understand the differences between a disability and a functional ability. For example, if someone has cerebral palsy and they limp when they walk, they certainly have a disability, and they may require a cane or a walker to walk, or a wheelchair or other device. You need to help them ensure that they can carry out activities of a normal life. So they can perform, but they have an impairment, right? But they can still function. And they have a disability. So you have to understand the difference between these terms. What we do when patients come into the hospital is we do a functional assessment. We assess their ability to perform activities of daily living, which would be things like bathing themselves, getting to the bathroom, washing themselves. What is their ability? Our focus is to continually assess the patient, and our goal is to facilitate independence to the highest level possible. So the care is directed toward promoting health and wellness, as opposed to them being sick and us doing everything. We want them to do as much as they can for themselves. Lots of interrelated concepts that you will go over during the course of your learnings in this program. Lots of them. So perfusion is breathing and lung capacity, but that impacts functional ability, right? Because if you're weak, you can't do these things. Everything impacts functional ability. Cognition, development, culture, nutritional status. So this is a very important concept. And lifespan considerations. So we're learning lifespan, we're learning concepts across the lifespan. So when we think about developmental stages of a child, their functional ability increases as they mature, right? They can bathe themselves, they can feed themselves. And sometimes when someone has extended into the elderly, maybe they're 80 or 90 years old, they can't feed themselves anymore, so their functional ability changes. So it changes over the lifespan, and you have to be able to understand that and help them cope, utilizing their psychological status, their development status, their physical health, understanding their psychosocial health and their cognitive abilities. All of these things play a part in functional ability. Risk recognition. So there are multiple risk factors for impaired functional ability. There could be someone with developmental abnormalities, maybe a trauma, physical or psychological. They could have a disease. It could be a long-standing chronic disease, or it could be acute, so they could overcome it and go back to normal with their functional capabilities. Social and cultural factors also impair, or play a role to impair. Advanced age, brain function, depression, so that would be a mental health issue. That would really impact somebody's ability to take care of themselves if they're so depressed. They're not getting out of bed, they're not bathing or eating, right? And comorbidities, which are comorbidities are additional diagnoses, multiple factors involved, and socioeconomic factors. So all kinds of things impact someone's functional ability, and nurses have to recognize that there are assessment tools. It is recommended that ongoing assessments occur because things change during the health and wellness process during the age. The components of a functional assessment. So, a comprehensive functional assessment is time sensitive. It should occur between all disciplines taking care of the patient, and there are many indications for a functional assessment. Maybe there are developmental delays in children, so they definitely need a functional assessment. Maybe the adult had a stroke or had kidney failure or some type of change in mental status, so a disease process that changed ability, or mental status change that changed desire or ability or recognition, or maybe just a frail elderly person who is so frail that they don't get help, something can happen to them. There are tools in place, so worksheets that help you perform a functional assessment. It could be a questionnaire. So they could check boxes on a questionnaire, or they could have them do things and watch them. The goals are the same. The goal of a functional assessment is to determine how much assistance is required. They could be, in a hospital setting, you'll say, they don't require assistance, or they're a partial, or they're a total. A partial means they need a little help. Who knows what that little help is, right? They may need you to set up the tray table and bring it to them and put the fork in their hand to eat, or put the wash rag in their hand and they can clean their face and you have to clean everything else. Or a total means someone else does everything for them. So no assistance, partial or total. And we need to understand the level of difficulty for the task. But the whole goal of delivering care to somebody with a functional impairment is to help them function to their highest level. And this is, I'm going to give you an example of helping somebody with a that. Maybe a patient who is very ill and weak and needs frequent rest periods. And it's a frail elderly person that takes a long time doing something. When you're the nurse helping them to bathe, they can do it, they just need more time. Sometimes it's easier to just get in there and clean them up yourself. But that's not okay. That's not functioning to the benefit of the patient. Our goal is to have them be as independent as possible for themselves, to prevent a further functional decline, or to prevent them from getting depressed that, oh, they have to do it for me because I can't. We have to encourage them that they can. And sometimes this really takes multidisciplinary effort. A lot goes on. So things we can do to provide patient education to help maintain a high level of functional ability are listed on this slide. Some nursing interventions to manage functional impairments are things like self-care assistance with dressing, toileting, bathing, ambulating, shopping, cooking, eating. Fall prevention measures. So in the hospital, we're going to put yellow socks on, we're going to put a wristband on, we might put a sign up. But in the home, we're going to educate everybody to get rid of the little rugs on the floor so they don't slip, to put the walker close to the bed, maybe to reposition the bed close to the bathroom, or to move the patient where they're not going up and down steps. Or maybe they don't know how to use their walker and we're going to teach them how. So there's all kinds of things we can do as nurses to help somebody minimize, manage their functional impairment. Now we're going to the concept of mobility. Mobility is being mobile, right? So think about common examples of impaired mobility and how do these differ by age? So there's some infants. You know, they can't walk, they can't crawl, so they require help with everything. And then they can crawl. And then they're really mobile. Young children who run around and they can fall. They fall off things. They run into things. Adolescents. Adults, older adults, their mobility, they might be a little shaky. And so they might have trouble. So across the lifespan, mobility changes. There are some other terms under the umbrella of mobility concepts. So immobility is the inability, right? Disuse syndrome. If you don't use it, you lose it. When you think about mobility, you have to consider muscles, bones, and joints, and the ability of all of them to move. Think of the elderly person who has arthritis. We know that is an inflammation of the joints, and it may cause pain or make the person slower to function. Think of the person who doesn't walk well because they had a stroke. They may still walk, so they have partial mobility, but not full mobility. So the nerve damage impacts their mobility. When we consider someone's ability to move, we want to consider consequences. For example, if someone is completely paralyzed, they totally depend on another person for everything. Feeding, bathing, toileting, anything you can think of, they're totally dependent. What about turning them if they're uncomfortable? Or if they're laying on their arm and they don't realize it? They could cut off the circulation and actually necrose their arm because it's not getting blood flow. But nobody knew because they didn't say anything because they couldn't, because they were completely paralyzed. But other people have to take care of every single detail or problems will occur with immobile people. It's helpful if an immobile person can at least speak or call for help, but if they can't, and someone doesn't diligently care for their physical body, not to mention their psychological being, they would possibly have skin issues and even issues that extend to the muscle if pressure is put on it for too long. People at the greatest risk for mobility injury, mobility-related issues are traumatic injury patients, brain injury patients, spinal cord injury patients, bones, joint, and muscle issues, neurological conditions, and many other chronic conditions. And we as nurses must learn how to take care of them. The elements of a musculoskeletal assessment are listed here. We perform a complete musculoskeletal assessment and a mobility assessment in order to recognize when someone is at risk for compromised mobility. So across the age of a person, the lifespan, infants, children, and over adults, we want to inspect joints and muscles. We want to assess muscular strength. We want to observe their balance, gait, and posture. There are diagnostic tests that can be performed to examine issues that might preclude or prevent people from having full, complete mobility. And they're listed here. There are primary prevention things like regular physical activity. If you don't have activity and you're laying in your bed, you have mobility problems. You're going to be so weak. Protection against injury. So people who play football, for example, or runners, they have to protect themselves against injury. You have to have optimal nutrition to prevent musculoskeletal issues and mobility issues. And definitely fall risks patients require fall prevention measures. So there's diagnostic tests, there's primary prevention, and there's also there are also many screening tools for mobilities. There's an osteoporosis screening tool. Osteoporosis is the breakdown of bone. It happens when people age, especially in women. And there are national screening tools. There are fall assessment screening tools. Fall assessment and mobility, they go hand in hand. We have to understand what are common screening tools and when they should be used. And then there are mobility interventions that we can do to help patients. We can turn them so they don't get bed sores or cramps or bruising. We can keep them in proper body alignment so that they don't get crooks in their necks, so that they don't get cramps, so that their body feels more comfortable. We can assess their skin, so they don't have skin breakdown from lack of mobility. We can perform something called range of motion. There's all kinds of things you're going to learn in your 106 class that we can do to help people with their immobility. It is a nursing function, not just for physical therapy. We can do exercise. We can walk with our patients. We can exercise their joints. We can help them stretch. There are drugs that can be used. That arthritic patient can use an anti-inflammatory or pain medication. We can give them nutritional supplements so that they get energy and strength so that they're able to be mobile. There are also surgical interventions, and there are immobilization things. So if I broke my finger, I can have a cast so that it can heal better. If I have cerebral palsy and I can't lift my foot to walk, I can put a brace on it, so a splint or a brace to keep it in good alignment and keep it at the right degree of flexion so that I can walk and don't drag my foot. I can use pillows, I can use slings, I can use all kinds of immobilization devices. And I can also use assistive devices. I can use crutches, canes, walkers, wheelchairs, prosthetic legs, anything to help me be mobile. That's it. That's our presentation for functional ability and mobility. Thanks for listening.